Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome William Wertheim. He is the Executive Vice President at Stony Brook Medicine. Today's Kevin MD article is America, our healthcare workforce training isn't evolving alongside our needs. William, welcome to the show.
Thank you for having me.
All right, so just briefly share your story and tell us about the Kevin MD article.
Sure. Well, I am a general internal medicine physician. Been practicing at Stony Brook since 1996. Finished my training about 2 years before that. And I spent a lot of time as an educator for internal medicine residents and then all of graduate medical education. And then I had the good fortune to be able to be in charge of our health system. So here I am. The article really comes from both looking at what our needs are as a health system, as well as looking at my own practice over the last 30 years. You know, when I started out doing primary care internal medicine, most of my patients were kind of a variety of early middle age to older patients. And now it's almost exclusively elderly patients, including people in their 90s and 100s. And it's reflective, I think, of where the population is going. So in our county, Suffolk County, New York, which has got 1.5 million people in it, it's estimated that by 2035, about a quarter of that population will be over the age of 65. Those are people who have a lot more and different healthcare needs that we don't necessarily accommodate as well as we should in our health system.
All right. And what are some of the core reasons why that's happening?
Sure. Well, for one thing, there are fewer people who are interested in geriatric focused specialties. Geriatric medicine itself is very undersubscribed. Many programs, I think the majority of programs go unfilled in the match each year, even though they're very robust and they're very widespread. In addition, many of the fields that also are required to take care of older patients, for example, nephrology, again, these are fields that don't get as much interest from students or residents as other fields, which perhaps are viewed as being more exciting. Yet at the same time, these are very complex patients who require a lot of different kinds of care and a lot of different kinds of physicians, and also require more in the way of coordination because they do have more medical problems.
For those who aren't familiar with the path of being a geriatrician, just outline how many years it takes and what are some typical pathways one takes to become geriatricians.
Sure. The most common way is to do an internal medicine or a family medicine residency, which is 3 years, and then a 1-year geriatric fellowship. A number of programs have extended the geriatric fellowship to 2 years and combine it with something like they spend half their time being a hospitalist so they can really earn more money than one might as a fellow. But it's not a very lengthy training, especially when you compare it to things like neurosurgery or interventional cardiology, that kind of thing. So it's certainly shorter a pathway. So I think there's other things that make it less appealing to most graduating medical students.
And when you say in recent years, these geriatric fellowships are going unfilled, can you estimate what percentage are being filled?
Less than 50%.
Really?
Yeah.
And from your perspective as a medical educator, what are some of the core reasons why you feel that a lot of these students aren't pursuing fellowships in geriatrics?
Well, one factor is, the appeal of technology is often found in a lot of surgical or interventional fields. And I get it. It's very exciting to be able to, use a cool new tool to be able to do surgery or something like that. There really isn't a lot of that in geriatrics. There's new information, but we don't have a lot of tools that are kind of fun and fancy and require specialized training in the use of that tool. So that's one thing. Another thing is that it is easier to think about when one thinks about the enormity of one has to do as a physician, and this, that it's easier to think about focusing in on something very narrow than focusing in on the widest array of things. And there's a lot of that in geriatrics. It's a lot of talking to family members and counseling people and having very difficult conversations, right? You have to tell people maybe it's time to not drive a car anymore. Maybe it's time to not live independently anymore. And while those are necessary conversations, they're not always the most appealing or most comfortable things for clinicians. And even with training, it may be more satisfying, or people might think it's more satisfying to simply do a procedure, walk in, walk out, and not worry about the rest.
Sometimes when we talk about these issues like primary care shortages, geriatrician shortages, a lot of times I find it's because a lot of medical students don't have great role models in these fields, right? And
Mhm.
then sometimes when they rotate through, they just see the enormous amounts of bureaucracy and obstacles. So it's not always the best foot forward. So at a place like Stony Brook Medicine or other medical schools, what are some typical exposures that students get to geriatrics?
Yeah, I think you're absolutely right, and I know you addressed this in a recent podcast. So our medical students all do a primary care rotation where they are getting an ambulatory experience with primary care doctors who in their offices, some of them family medicine, some of them internal medicine, some of them geriatric focused. And especially the internal medicine doctors those patients tend to skew older. So that's one way. They do get some other training in geriatrics as well, and through both clinical experience and in their medicine and contemporary society, which is kind of more of a discussion format to deal with some ethical issues that people are likely to face or understanding cultural issues, etc. And they do talk about things that are relevant to older patients as well. But you're right, there aren't a lot of role models. There are some. We have a primary care training program in internal medicine. We have a family medicine program. We have a geriatrics fellowship. But that said, it's not the preponderance of the student's experience.
So, what are some paths forward? I think from your perspective as a medical educator, what can medical schools and residencies do? And then broadening the scope, what are some policy options that we can consider to tackle this issue?
Well, I think making sure that people, when students get the kind of experience and exposure to geriatrics, that it is really a robust experience, and the experience focuses on some of the particular rewards of taking care of older patients. I think a second thing is making sure that people training in specialties which relate to older patients more frequently also get more of a training in geriatrics. So, for example, a lot of orthopedic surgeons deal with older patients.
Hmm.
Those are likely to be the ones who need joint replacements or who have hip fractures when they fall. And so, I think it would be helpful and I think provide a better experience if specialties like that or cardiology or nephrology could have more kind of appreciation and understanding of some of these issues. A lot of it relates to, I think, the care plan, the what are patients really interested in from their lives. It's one thing to say, well, you have heart failure, but it's another thing to know that they want to be able to, walk 3 blocks to their grandchildren's house. And if you can sort of get them to understand that, then I think it changes the dynamic. So I think that would also provide a better experience. In terms of policy, I think that it would be great if the fields of primary care and geriatrics were more highly valued, and a lot of that relates to how we reimburse our clinicians and people who provide other kinds of care for those populations. I don't, I'm not saying it should be at the expense of something else, but I think we could do a lot of good and probably overall bring care costs down if we could make clear that we're valuing and promoting more primary care, preventive care, and the kind of care for older patients that make small changes that have large effects over time.
When you talk about a robust geriatrics experience for the students, tell us more about what exactly that entails, some of the rewards that the field of geriatrics provides, and perhaps a type of student that experience may appeal to.
Well, I think even though we've made a lot of strides in changing the experience of medical students, we, for example, like many schools, have this primary care experience, which is ambulatory. A lot of the learning, particularly in an internal medicine clerkship, still occurs in an inpatient setting. And that's about the worst place
Hmm.
for an older patient, as you know. So I think more of the experience in learning about the value and the enjoyment of geriatrics could be done in an outpatient setting. And I also think, although skilled nursing facilities play a very important role, I think that that's also probably the wrong place to be, because more of those patients have cognitive dysfunction. You're dealing with people who may be bedbound, and you know, in some cases there aren't other family members around. I think as much as we can get the experience of students in an environment where people are in their homes or people are in an outpatient setting where they are able to go back and forth, I think those are really beneficial. Another thing that I would say is, as much as I love some of the technology, which has allowed us to expand our reach, really in many cases driven by COVID, such as telehealth, recognizing where that fails, particularly for older people, who may have trouble using technology, which to the rest of us is simple. I remember talking about using Uber with somebody who was in their mid 90s, and it probably took this fellow about a half an hour to
Hmm.
figure out how to call an Uber. To us, that would be 2 or 3 seconds. It's very difficult, I think, and I think we have to recognize that we cannot necessarily replace some of the care that we might for a younger patient with technology. We have to be careful.
And just to your last point, especially during the pandemic with these virtual visits, just assuming that all our patients have access to the internet and being able to navigate what we think is simple technology like a Zoom call or a virtual visit can be very, very challenging for the older population.
Absolutely.
You mentioned about geriatricians needing to be more valued. From your perspective, students who are choosing fields, how much does that reimbursement factor play into their decisions, knowing that a lot of these students have medical loans to pay off? Is it something that is an explicit choice? Is it something that they talk about? Or how much do you feel that those financial pressures that students already have factor into the eventual career decision that they choose to make?
I think it is definitely a factor. It's not the only factor, and I would never say that it is. But I think that it is often unspoken. I actually remember there was a classmate of mine in medical school who sat down in a lecture hall one day and said, I really would love to be a pediatrician, but I got to make more money than that. And
Hmm.
so I'm going into GI. And I'm sure that, I'm hope that he is actually, I know that he's still in GI, so he must be enjoying himself. And it's a great field. But, I always think of it from this perspective. If you Every field that we have available to us in medicine does good for people, right? So if you have the choice of being of value and doing good things for people and helping them and curing them, and in one field you can make 5 times as much as another field, and you're kind of on the fence about which to do, it's hard not to choose the field that you would be making a lot more money. And on top of that, life has gotten a lot more expensive. I think people in their 20s and 30s have a lot of difficulty thinking about buying a house or starting a family, because those things are much more expensive than they were when I was in my 20s and 30s. So I understand it. I'm not being critical at all. And again, it's not the only thing that plays into it. I think the appeal of some of the really amazing technology that we have available to us. The sense that, you have a discrete task that you can take care of and know that you're done and move on to the next thing, I think is also very appealing to a lot of people. Geriatrics, primary care can be a little messy, right? Because you keep having these relationships with people and they keep coming back. I think it's wonderful. I've enjoyed it tremendously in my career. But, some people don't necessarily enjoy that as much. And it's not as support, I would say when I say valued, it's not simply a matter of money. But you mentioned this, the burden of paperwork and bureaucracy, the number of times you have to contact insurance companies to get things authorized, or balancing the information that you're getting from multiple different sources. These are all pretty challenging.
In your article, you also talk about the need in rural areas for physicians and primary care physicians, and sometimes our training programs isn't really addressing that need.
Yeah, absolutely. I think again, it's understandable why people who are physicians would want to avoid rural areas. If they want to have families, although the cost of living may be less, it may be harder to find, the schools, the quality that they had growing up for their own children. They may be far from family, etc. But there are people there that need care, and they have, I'm not an expert in rural health, but certainly there are challenges that people in rural areas face that, in terms of access, having to be able to get transportation to get medications or, get appointments. I think those are all real problems. And, it's hard to just sweep that under the rug. We're not considered a rural area by the federal government, but we have some pretty rural and remote areas in Suffolk County, particularly in the North and South Fork at the very east end of Suffolk County. And the community in the east end of the South Fork was desperate for years for access to emergency care. In the summertime, particularly when there's more summer traffic, it could take 2 to 3 hours to get to the nearest emergency room. So, we opened up a new freestanding emergency department on the eastern part of the South Fork. And that's been, very great advance for them. But really, it takes a lot of effort and it takes a lot of time, and it also takes a lot of money, and many rural areas can't afford that kind of investment. So I think we have to be creative. Certainly technology can help, such as telehealth, but I think we have to think about what other models might there be. And I don't have the answers, but I think it's a real important problem.
So you have a unique perspective being on the executive staff of a major academic medical center. How difficult is it for academic medical centers, which of course provide the majority of residency positions in our country, to make the necessary changes that we're talking about?
Well, it is difficult because we can't do it in isolation. So if there's a degree to which we can change our curriculum, but if I say expanded our geriatrics fellowship or our primary care training programs 200%, that doesn't mean I would get any more applicants to our program. And, there's just a limited pool of people who are applying. So it cannot simply be one system that is trying to change it, and certainly not change it to mimic what we've done so far. And I think that's probably not a successful strategy. I think, this is the kind of thing where we have to pilot a couple of different ideas. And some of it may be having advanced practice providers provide more care, or, be coordinated with physicians. Some of it may be using telehealth technology. Some of it may be, using drones to deliver medications, that kind of thing. And some of it may be, changing the curriculum so that more people can provide that kind of care even within their specialty. I don't know that there's one easy answer. I think we have to treat this like a performance improvement project.
We're talking to William Wertheim. He is the Executive Vice President at Stony Brook Medicine. Today's Kevin MD article is America, our healthcare workforce training isn't evolving alongside our needs. William, let's end with some take-home messages that you want to leave with the Kevin MD audience.
Sure, my pleasure. I think that we really have to think broadly and not simply assume that what worked for us 20, 30 years ago is going to continue to work. But I think we also need to remember that at the heart of what we do, there is a person. There's a human being who is looking for advice, looking for care. And I do think that that sometimes gets lost, especially now when there's a lot more distrust of the medical system. Having that kind of long-term relationship, I think, is the best counter to that kind of mistrust. I find when I'm talking to my patients that I've been caring for 25 or 30 years, I can have the conversations about what they're really afraid of or what they like or don't like or what they might accept or don't not accept. And other people can't really have that conversation. So I encourage people to remember that despite the fact that we may need to make some changes, the core of that doctor-patient relationship is really continues to be the essence of what we do.
William, thank you so much for sharing your perspective and insight. Thanks again for coming on the show.
Thanks for having me and hope you have a great day.